Good afternoon, and welcome to COVID-19 Restrictions, Recovery, and Reopening. The mission of Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We welcome you to the 6th webinar in our COVID-19 webinar series. I'm Tonya Winders, the President and CEO of Allergy and Asthma Network, and today we're pleased to be joined by Dr. Vickram Tejwani and Dr. Purvi Parikh, who will share their experience and expertise with the novel coronavirus. Dr. Vickram Tejwani is a pulmonary and critical care physician at Johns Hopkins University, where he came after completing his residency and chief residency at the Cleveland Clinic. He treats patients with chronic lung conditions in clinic and hospitalized patients in the intensive care unit, including the recently serving in a COVID-19 ICU unit. He's on the National Institute of Health Fellowship Award to study COPD and asthma separately, and is also working with Allergy and Asthma Network to create a core set of asthma outcomes for clinical trials. Dr. Parikh is an adult and pediatric allergist and immunologist at Allergy and Asthma Associates of Murray Hill. She is currently on faculty as clinical assistant professor in both departments of medicine and pediatrics at NYU School of Medicine. She's been a passionate health policy advocate and also serves on the board of directors of the Advocacy Council at the American College of Allergy, Asthma, and Immunology. She frequently travels to Washington, D.C. to influence policy, testify before the government, and advocate on behalf of her patients, and also on behalf of organizations like United Nations Foundation, Shots for Life, and Allergy and Asthma Network. We welcome you both to today's webinar and look forward to hearing from you after looking at some of the current information on COVID-19. So this is the outline for our time together today. We will go over a current state of COVID-19. We'll also take a look at COVID-19 and lung disease, and then we'll turn our focus to some of the reopening questions, restrictions, and recovery questions that are evolving as we continue throughout the COVID-19 crisis. So as you can see here, this again is a slide that we've all become familiar with from the Johns Hopkins Coronavirus Update Center. Here you can see that as of today, there are 4.3 million confirmed cases of COVID-19 with approximately 300,000 deaths globally. Again, this is a wonderful resource that allows you to go and look at regionally, by country, and also by region of the world, the impact of COVID-19. As well, we always want to reaffirm that the CDC is a trusted resource when it comes to COVID-19. And again, you can look at some of the case reports and the data specific to the US at the CDC's website. You can see here these maps that show us from mid-March to mid-May how the case counts have progressed. You can also see today's numbers. As of yesterday at 4 p.m. here in the United States, we had 1.3 million cases confirmed with 21,467 new cases and 82,246 deaths, with a total of 1,426 new deaths. And we want to reinforce today that these are not just statistics. These truly are indicative of moms, dads, sons, daughters. Every single life matters and every single life counts, whether that's here in the US or globally. And that's why we continue our commitment to sharing the most relevant information in a timely fashion. In the headlines over the last week, we certainly have had some good news in that we have surpassed now over 10 million tests conducted here in the United States. But we've also had some troubling news as 2 cases were actually identified in the White House staff. And I think for the first time there were discussions around members of the administration's family being exposed. We also had some good news in the fact that now we understand there are over 100 different vaccinations for COVID-19 under development, and that in fact, the very first vaccine could be ready in some limited quantities and capacities in the 4th quarter of this very year. So again, we've seen that emergency response and the response of FDA to accelerate the emergency use of some of these treatments and products. Also, we heard from Dr. Fauci, who said clearly when he talked about the prospects for treatment or vaccine to combat COVID-19 in order for classes to start as scheduled in August or September, he replied that that was a bridge too far, that perhaps, that was too optimistic to think that that treatment or vaccine could be on the market and approved and ready for widespread use in that near term. We also heard from Wuhan, China, that they are planning to test all of their 11 million residents for coronavirus in a matter of the next 10 days. So again, that level of antibody testing and a better understanding of the epidemiology of the coronavirus for those that are asymptomatic, symptomatic, and recovering will be much more evident as that testing is conducted. Additionally, in the news, there's been a growing body of research that suggests the virus was actually spreading in the US and perhaps even here weeks, if not months, before we began the official case counts in February and March. And we've definitely heard from people saying, well, I think I must have had this in December or January. I had these symptoms. I tested negative for the flu. So this is consistent with, I think, anecdotally what we're also hearing at the network. There also has been some reports of a new skin issue with COVID-19. This terminology of COVID toes sort of gained some traction in the media and the news over the last few days. And perhaps we'll get to hear from Dr. Tejwani about his experience if he actually saw this in the ICU. But those red or purple bumps that are tender and tend to go away in 2 to 3 weeks are those COVID toes that have been reported. But the authorities and certainly physicians have warned us, these aren't necessarily COVID-19 toes, that it's very common in viruses to see this manifestation. And so again, we always have to take the headlines and the frontline news and temper them with what the experts are saying. So this chart here shows you the COVID-19 cases in the US by the date reported. You can see that clearly when we look at new cases by day, it appears that we had our peak in the week of April 6th, and that now we are continuing to see that decline as we move throughout the early weeks of May. Again, I want to call your attention to our COVID-19 Information Center. Allergy and Asthma Network was at the forefront of thinking about how we would quickly respond to COVID-19, and we developed this Information Center in early March alongside our first webinar. There you will find all of the webinar recordings, our patient program with an ATS recording that we did of actual patients who have recovered from COVID, as well as infographics, fact sheets, Q&As, podcast. Definitely, we have state-by-state guidance on how the states are reopening so that you can get that specific information and determine the best way for you and your family to reinitiate contact and really begin to change that behavior of staying at home completely over the coming weeks. So now I'm going to turn the mic over to Dr. Tejwani, and he will carry us through the next conversation of COVID-19 and lung disease.
Perfect. Thank you, Tonya. And I just wanted to thank you, Sally, and the Allergy and Asthma Network for organizing this and inviting me to speak here. So as you've heard, I spend my time in the intensive care unit, which more recently has effectively become what we're calling a COVID intensive care unit. and treating patients with chronic lung disease, predominantly asthma and COPD. So I'm here today to talk about the implications for people with chronic lung disease, and I think broadly speaking, there are three of them. So one, which I think is probably appropriately the most significant concern, is that if you're exposed or contract the novel coronavirus, that there's a higher risk of more severe disease. And I'll delve into this a little bit more in detail later. The second one is that some of the treatments for chronic lung disease, particularly systemic steroids, which are the pill form of steroids, not the inhaler, can actually make you immunocompromised and then also put you at higher risk of disease. And a third one, which I think is under-recognized, and as this the effect of this pandemic nationally is becoming more and more protracted, is becoming more relevant, is that usual healthcare resources, doctors, office appointments, elective procedures, tests such as breathing tests or PFTs, just aren't be able to be performed in the same fashion as they were before this. And I think particularly for those with chronic conditions that necessitate outpatient management, that's an important consideration. I wanted to talk broadly speaking a little bit about what we're learning about COVID-19. One thing that's becoming clearer and clearer, as Tonya mentioned with these antibody tests, is that there's certainly a high proportion of asymptomatic cases. This actually makes tracking the virus and preventing its spread even more challenging. What you're seeing on the right is just an illustrative example of this. This was from late March in New York. There were 215 pregnant women coming into their usual outpatient appointment and getting tested for the virus. Of the 215, 33 were positive, but that big orange triangle you're seeing there is the ones that did not have any symptoms. We're actually 90% of this population. So this was a young and otherwise healthy population, but similar tests have been done during prison outbreaks where they test everyone. And again, it seems that 80% number is pretty consistent. Lastly, they performed that at an outbreak in a nursing home, one of the early nursing homes in Washington. And generally, these are people that are a little bit older, a little bit more chronically debilitated. And that number was still at least 50%, 50. So that means a large proportion of patients that are walking around with coronavirus and possibly infecting others don't actually have symptoms at that time. Next, I wanted to talk about what it looks like if you actually do get this and what the implications are for the lung. I think there are three basically, which are pneumonia, which is an infection of the lung, ARDS, which is a very severe form of this, and the third one, which is becoming more apparent recently, are blood clots. So to briefly describe what a pneumonia is, it basically is when a virus or a bacteria gets down into the lungs, it causes inflammation there. This leads to low levels of oxygen. Sometimes this can be managed at home or on a regular floor in the hospital, but other times it does become bad enough that you need ICU level care. If this is a mild case, it's unlikely that there's persistent lung damage. Most of these patients that are not on a ventilator will recover without any permanent type of damage. If this continues to become severe, you can develop a syndrome called acute respiratory distress syndrome, or ARDS. This is actually a response of our own immune system trying to ward off the virus, essentially leading to blood leaking into our lungs. This almost always has the need for a mechanical ventilation and a breathing tube, and it can be fatal. What we're seeing with our COVID cases for patients that get put on a mechanical ventilator is that the mortality rate, or the amount of people that die when that happens, is about 25%, or 1 in 4. So I do want to highlight, there's kind of zooming out for a moment, there's a large proportion of cases that are totally asymptomatic, some that will become sick with pneumonia, some that will become even sicker with the most severe form of pneumonia. And of those, about 1 in 4 will unfortunately pass away from the disease. The third lung manifestation we're seeing of COVID-19 is what's called a pulmonary embolism, or a blood clot in the lung. Most of the things we've talked about so far, the pneumonia, the risk for ARDS, actually can occur with any virus or even a bacterial infection. and as Tonya pointed out, it's really the same for that toe inflammation. That all kind of reflects what we would call a viremia, or basically just a virus in the bloodstream and in the body. One thing we are seeing that is unique to COVID-19 compared to other viruses is that it seems to make our blood hypercoagulable or very sticky. And we're seeing a high proportion of blood clots that can either form in the lung themselves or elsewhere and travel to the lung. That also makes it hard to get into oxygen into the body and requires long-term treatment with blood thinners over the course of several months. In its most severe form, it can actually affect the pressure in the lungs and lead to high blood pressure in the lungs, or in a very severe form, even cardiac arrest. So this is what COVID-19 can do in the acute setting, and I think appropriately, much of the focus is on the mortality rate and the likelihood of death. I think it's important also, however, to recognize that even for that proportion that do survive, it's not an immediate return to normalcy. There's a condition called the post-intensive care syndrome, and this can happen with an ICU hospitalization for any reason, where after leaving the ICU, there continues to be physical deconditioning, psychological symptoms that have actually been described very similar to PTSD, and cognitive symptoms, which is not being able to think as much as well as you were used to before being in the ICU. What you're seeing there is actually a picture of somebody who is walking with the mechanical ventilation or with a breathing tube in place. So we try here, we have a very kind of robust protocol and as best we can to continue physical therapy and rehab even when hospitalized to try to mitigate the long-term consequences of this, which can be that the muscles that you need for breathing, which are particularly important for those with other chronic lung conditions, can get weakened. And if you have other types of allergies, for example, sinus disease or food allergies, that this does not serve as a trigger for new asthma as a consequence. So the three major influencing factors of what caused COVID-19, one is the disease severity. So mild cases, there's less likely to be any permanent damage or irreversible repercussions. And the thing that determines disease severity the most are what other health conditions are present. This has been studied in the reports out of China, there are reports out of our data in New York. We're looking at this in our local cohort in Baltimore and really across different countries. And what seems to be the most consistent is that advanced age, obesity, and heart disease are the three most common predisposing factors for more severe disease. And the specific heart disease is coronary artery disease. The reason I have asthma and COPD there as a question mark is we're definitely seeing more asthma and COPD patients hospitalized with this disease, but those are actually diseases that are quite common in the population. So I would say regarding those two, there's definitely a higher risk compared to not having it, but it's not as high as advanced age, obesity, and coronary artery disease. The other influencing factor is treatment, and I think the thing here is just to make sure that if there are symptoms or a concern for this, to get hospitalized early. You can transition from that pneumonia to ARDS picture quite quickly, and even more so with this particular virus. So this is not something that's worth trying to fight at home or wait to seek medical care and testing for. As we start to look to the post COVID-19 pandemic, which I think appropriately is now starting to be described as a new normal, many of these patients that have recovered will continue to need medical care, and particularly on the physical therapy and the pulmonary rehab side of things to continue to strengthen back to their functioning status before an infection. This is going to create basically a new need for predominantly respiratory therapists and physical therapists. So, and we're starting to set up COVID-specific post-ICU clinics to start, and this is being done across the country, to start focusing on these patients to the continued path to recover to normal. So it's a lot of information. I kind of want to highlight what it means now. I think, unfortunately, and a part of what makes this so particularly challenging psychologically is that still continues to be a lot of uncertainty. We don't have a clear end in sight. In the meantime, I think we all need to continue all CDC recommended precautions with maintaining 6 feet, wearing a mask in any type of close space. And I think what's become apparent now is that an absence of symptoms does not equate to being non-infectious. So unfortunately, with the flu and other viral illnesses, when somebody has it, you kind of know to avoid that person. This really is not the case here, which makes transmission much easier. Another point I would just want to highlight is that with either telehealth, phone calls, or whatever it may be, that there continues to be a plan with your providers for continued management of chronic conditions. Because unfortunately, any medical condition that was present before this has not magically disappeared. It continues to need care and attention and focus to not have that becoming worse as well. As Tonya mentioned, there's really been a remarkable effort amongst the scientific community nationally and globally to try to fast track a lot of treatment and vaccines. And I think there's reason to be hopeful, and we'll kind of continue to monitor that, but just wait to see, make sure that whatever we do use is rigorously studied. And the last thing I want to point out, and I think this really applies to everyone, myself included, is that this is a challenging time. There's a lot of uncertainty. We're having to, in many cases, isolate ourselves from loved ones or friends. So just to be sure that you're continuing to do things that make you happy, whether that's taking a walk or whatever it may be for you, to make sure that you're preserving your own psychological well-being as well.
Great. Thank you so much, Dr. Tejwani. That was very informative and helpful from those front lines of the COVID ICU. Now we're going to turn the discussion over to Dr. Purvi Parikh, who is going to give us an overview of restrictions and recovery.
Thank you. So the pandemic is still with us. It's been 2 months. It's been a very long 2 months, but we are progressing through the stages of this pandemic. And there's, different intervals and framework that, goes into any pandemic or any public health crisis. And that goes from, the recognition that there's a crisis, initiation, acceleration, deceleration, which we're hoping that we're approaching now, at least here in New York, preparation, and then, of course, investigation. So the first stage, the investigation, is when, we first started identifying this novel virus in people. And then, targeted monitoring and investigation usually follows, as well as risk assessment, and does the virus have the potential to cause a pandemic? And as we all know, by the time the virus was spreading in the US, we still didn't have good monitoring and testing in place. So that may have cost us some time in underestimating the risk of the virus. As now we're getting autopsy reports back from even February that were showing that the virus was very much in our community here in the US. And recognition, of course, increasing numbers of illness are identified, potential for spread person to person. So here in the US, I recall, we didn't identify the initial spread until the first week of March. And we actually now have reports showing that it was probably earlier than that. We were under the assumption that a lot of the cases that had come into the US prior to that were isolated, whether they were from travelers or a cruise ship or, people isolated on military bases. But probably our delay in adequate testing and widespread testing may have led us initially to have a false sense of security. Public health actions, need to focus on control of the outbreak and, of course, treatment of patients. And then initiation. So, a pandemic is identified, and people often ask, what is a pandemic compared to an epidemic? So epidemics are when large populations are affected, but pandemic is usually once it has hit globally. So multiple or majority of countries worldwide have been affected. So that also occurred here in March, about, I would say, mid-March, right before Friday the 13th of all days, was when, the World Health Organization had declared this as a pandemic. And when this is declared, it's important, because that means that people are easily infected and the virus has ability to spread person to person in a sustained manner, which is what obviously we saw with COVID-19. And acceleration, or also known as the surge, or rapid increase in cases, is when we see that upward epidemiological curve, and susceptible people are getting infected. And generally, when this acceleration is occurring, it's very scary. We hear about it on the media, but we see constant increase in cases. Public health actions need to be taken quickly, and community interventions such as lockdown measures, shelter in place, closing of borders, of course, use of medications, and then working to prevent spread of disease and death. And here with COVID-19, it was quite unprecedented, because we've had other, obviously, pandemics and rapidly spreading situations, but never at this speed, and never in that quick of a pace, where we were having to come up with medications, treatments, testing modalities, while also the disease was spreading quite rapidly. And then deceleration, which is what we effectively will call, the phase. We all talk about flattening the curve, but this is even one step further. So yes, we want a flat curve, means that the cases are steady. Deceleration is that we're finally seeing those cases come down, and consistent decrease in new cases. So public health actions include vaccine development, monitoring and reducing community interventions, such as the school and business closing. So finally, here in New York, I think on Saturday, we reached levels that we hadn't been at since March 20th. So again, we're still seeing a lot of cases in the upwards of 300-400 a day, but at least now we're starting to finally see that peak coming down, so we can start talking about some of those things. And speaking of vaccine development, trials are already underway at multiple institutions. NYU, where I'm at, we've already started injecting people, and I was at the vaccine center this morning, actually. And then stage 6, preparation. So the pandemic has subsided, public health actions, again, we can't let our guard down. We have to continue monitoring. We don't want to see a second wave of infection or surge of infection. The second wave could be more severe. That's what we saw 100 years ago with the Spanish flu, that it wasn't even the first wave that was the deadliest. It was the second wave, because people, again, were so happy to be off quarantine and let their guard down too soon. So that is something we do not want to repeat history at. And of course, pandemic planning continues. So nationally, where are we? Nationally, we are still in the acceleration phase. So yes, while we are starting to see decreasing in the epicenter, unfortunately, we are seeing increasing of cases in other regions of the country. The duration and severity of each pandemic phase can vary on many factors, but the characteristic of the virus is paramount. And this virus, as everyone has said, whether they are newly practicing or been practicing 40 years, is unlike anything that we've seen before. Public health responses also are key in this, because the more aggressive, concerted, and organized the public health response is, the better that we can get the duration and severity of this under control. And then, U.S. COVID-19 cases include people who were infected while traveling, before returning to the United States, people who were infected after having close contact with someone known to be infected with the virus, and people in a community who were infected with the virus but don't know how or where they were infected. And there's a wonderful quote that the United Nations always says, is that an outbreak anywhere is an outbreak everywhere. We can't take these things lightly, because something around the world could be in our backyard tomorrow. So currently in New York City, you know, it's been a very unique time to be in the city. You know, we were hit very hard, especially in April. But luckily, as I had mentioned, on May 9th, we did start to see some respite, and the cases returned to what we were calling pre-surge levels. But again, we're still seeing quite a few deaths and hospitalizations on a daily basis, so we're nowhere near out of the woods yet. But, you know, we are starting to see decrease in hospitalizations, deaths, but again, there are strict parameters that need to be met before we even consider reopening. That includes a 14-day decrease in both hospitalizations and deaths. We also want to see a third of our hospital capacity open in the event that there is a second surge or second wave. And again, sufficient PPE should be there. And in New York City, you know, we're not quite there yet. Some of the upstate regions are close to these parameters. Currently, you know, there's 7 total parameters, and as of today, New York City is meeting 4 out of 7. So we're not close, but we're hoping some of the upstate regions may be able to reopen in May, but New York City is looking more closer to June. And the other interesting thing that has popped up in New York City, and also a bit concerning, is that in the last 10 days, we've been seeing quite a few cases of this pediatric multi-system inflammatory condition. And I myself have been consulted on a few of these cases here at NYU. And the reason why this is concerning is that up until now, we're hoping and we're under the impression that children were relatively unaffected compared with their adult counterparts. And if they did get sick, they were either asymptomatic or very mild in illness. But now we are seeing that they also are developing this inflammatory response, similar to how the adults have been having an inflammatory response. But the good news is still majority of children are doing very, very well. So I don't want to cause concern, just kind of give an update. Majority do very, very well. And even those that we've seen admitted with this multi-system inflammatory condition, if they're treated and recognized early and treated aggressively, they've actually all done fairly well. So at NYU, from personal experience, we've seen 5 cases. Some are similar to an illness called Kawasaki, which is also an inflammatory response triggered by an infection. And again, I would not panic. Majority of kids are okay, even those with this illness recover. But it is important to note because it does affect heart, lungs, kidney, and liver. So close monitoring is needed, and often in an ICU environment. And so, you know, do not delay seeking medical treatment if your child needs it. So what does that mean? You know, children get sick often. So it's really that child who has a high fever over 100.4 for multiple days that doesn't break easily. And also that you know your child best. So if you're noticing they're not acting like themselves, they're very listless, drowsy, they have rash, swelling of their hands and feet, red eyes, severe vomiting leading to dehydration, these are warning signs that they would probably need to be brought in. You know, again, kids get sick frequently, and so every fever or runny nose is not, again, a need to panic. But I know that there was a fear for some of these children of coming to the emergency room, especially in New York. And I just want to stress that they aren't acting like themselves, to not delay that treatment.
Great, thank you, Dr. Parikh. Now I'm going to address some of the issues around reopening and how this truly is an ongoing process that is evolving and changing on a daily basis. So again, we are evolving as we reopen states. Certainly state to state, there is different guidance, even different counties within each state. As Dr. Parikh mentioned, in New York,
Tonya, we can't hear you at this time. If you could try to figure out how to get your volume to work again, that would be wonderful.
Can you hear me?
Now we can hear you.
Sally? Okay, I apologize. I'm not sure what happened there. But as we were saying, some states are actually employing this red, yellow, green approach to reopening different sections of the state. And it's important that you find a reliable source of information to really understand what's best going on in your local community. Again, it is different from municipality to municipality. I am based outside of Nashville, Tennessee. The downtown area is completely closed, and 15-20 minutes out of the city, everything is reopening. So it's very important to know what your local municipality's guidance is relative to your community versus the communities next door. We know that this is challenging, especially as we are a democracy and we identify as a people of freedom and rights. We know that this has, definitely changed the way that we are living on a daily basis. And we recognize the seriousness of this pandemic and that it's been necessary to take some of these common actions to, as Dr. Parikh mentioned, flatten the curve. So here are some of the federal guidance on responsibilities in reopening. First, for individuals, continue to practice good hygiene. Wash your hands with soap and water or use hand sanitizer consistently. Avoid touching your face. Sneeze or cough using a tissue or inside the crook of your elbow rather than just openly sneezing or coughing. And then it's important to disinfect hard surfaces and items frequently. Again, we've got great tips on our website of ways that you can take steps to ensure that you're doing this properly. And then strongly consider using face coverings in public, specifically when you're in transit. Again, we know that if you are sick, it's important to stay home. Don't go out, don't go to work, don't try to go to school. Again, we haven't heard of many schools actually reopening at this time, but if that were to happen, definitely avoid those situations when you're not feeling well. And then contact and follow the advice of your specific medical provider. That's why at Allergy and Asthma Network, we've always advocated for you to have an ongoing primary care provider and an asthma specialist that you work alongside. So follow their advice and stay in close contact should you become sick. Next, there is federal guidance for employers. As employers, we're being asked to develop and implement appropriate policies when it comes to social distancing and PPE, the protective equipment that Dr. Parikh spoke about. In some cases, checking temperature before employees return to work, certainly taking extra measures for disinfecting and sanitation in common and high traffic areas, and then limiting all non-essential business travel. Again, most across the country are continuing to work from home or telecommute, but it's important to note that as we begin to reopen, we want to monitor those workforce and our employees, our coworkers, for symptoms. Don't allow symptomatic people to physically return to work until they've consulted their medical.
Tonya, I think we lost you again.
It's such an issue sometimes with internet in local areas that every once in a while we have problems no matter where someone is.
First, I'm back, I think.
You're
sorry
back.
about that. Okay, sorry about that. So I was just explaining that we do have a three-phased approach for individuals in this reopening period. In phase one, it is that shelter in place to isolate vulnerable individuals and ensure that they are avoiding all contact, doing that appropriate.
The slide you're seeing here is the slide that is part of the national reopening document. And as soon as Tonya is back, she's obviously working a little bit on her internet connection there. But
Yep.
it does.
I'm back, Sally.
Okay.
Sorry. Again,
No,
I
you're
apologize. I'm on a hard line connected, so I'm not sure what our issue is this afternoon. But at any rate, we were talking about the three-phase approach, and definitely, again, at this point, we're more in that phase 2 approach of vulnerable individuals continuing to shelter in place. And then as we enter into that phase 3, it will be those vulnerable individuals that can resume their public interactions, but certainly continue to practice that good social distancing and social hygiene when appropriate. Again, we at this point are not into that phase yet, and we would advise you to continue to take every measure possible to protect yourself and your loved ones. We really do believe that this is the common action that we can all take to be on the front lines of protecting ourselves and others. Again, this is that three-phased approach for employers. Most places across the country that we're hearing from now are moving from this phase 1 into a phase 2 approach, where they have been in a telework situation, they've closed common areas, they've minimized travel, and now they're moving more to encouraging telework, but also having a few employees come back into the common areas of the office. But in some states and in some communities, again, we have continued to stay in phase 1. So understand what your current situation is and take steps appropriately to encourage telework or minimize the ability to be exposed to other people. As we move into phase 3, then we'll resume that unrestricted staffing of work sites. And as I was saying before, I understand, definitely we've heard from a lot of patients and families who have expressed their frustration over the fact that this is democracy and that, you know, we want to get back to work. We want to certainly engage in that way, but we need to take these restrictions seriously and the reopening rules very considerably. We know that this is the only way that we continue to flatten the curve and limit the loss of life and the burden on our healthcare system. So a wonderful resource that we're using at Allergy and Asthma Network is this stateside.com blog. So if you go to the website at the top, you can also go to our website to see that since the beginning of COVID-19, now 145 bills have been introduced into state legislatures and over 1,100 executive actions have been in place. But here at this site, at this link, you can find your specific state, your specific region on what are the guidance regarding non-essential businesses, stay-at-home orders, mass gatherings, paid leave, and many other topics. Again, this is a multifaceted recovery. This pandemic has affected all aspects of our life. As you've heard throughout our COVID series, it's not only the physical and health aspects of life, it's also the social, emotional, and community aspects. Our spiritual lives have been impacted, our educational aspects of life, our political aspects of life, economic, employment, housing, all of these things have truly been significantly impacted. And on a daily basis, we're trying to strike the balance, the concern of public health versus personal rights. And it's why, again, we felt it was so important to focus our time today on those topics and discussions around recovery, reopening, and current restrictions. We would implore you to please partake in our COVID-19 registry. Again, this is even if you have not been diagnosed with COVID, we are asking everyone who participates in these webinars to go online to our COVID-19 registry. Share with us how your life has been impacted by COVID. It will help us to gain insights across communities, and it will also help us to have a deeper understanding of how we move forward and continue to face these difficult and unprecedented times. So from time to time, we'll introduce new surveys. You can revisit that site at any point over the next 100 days. Again, this data is extremely important for helping us to deal with the current crisis, to identify where there are segments of the population that are more exposed to the virus, more at risk, but also to help us identify individuals who have developed that immunity and who are moving forward with life. We also want to use this data to better understand some of the social determinants of health specific to COVID-19, how food, housing, education, and income have certainly played a role in the disparities that have been well reported throughout.
So we would encourage everyone who is listening to be sure to go to the COVID-19 website and make sure to the survey and make sure that you can participate so that we can be able to get a really solid picture of the data surrounding the COVID-19 viruses.
Great,
So
thank you, Sally. Yeah, I'm back. So thank you for picking up there. At this point, we do want to run into the time of our questions and answers so that we can get to as many of those as possible. So I'm going to go forward with our first question, which actually goes to Dr. Parikh. The question comes that if we were to remove New York from the reporting and from the statistics at this point, would the rest of the country still be in that surge that you spoke about?
That's an excellent question. And the New York Times actually had a really nice graph about this just about a week ago. So the short answer is yes. and it's because what we're seeing is that even though the curve is coming down in New York, we're seeing that other states have the curve is slowly increasing, has yet to reach the peak. Now, I'm not saying this to scare or panic everyone, because obviously every region is different and many things affect it, such as population density and what have you. But the important thing to note is unless we're literally testing almost every single person, we don't really know how widespread this really is. And until we have accurate testing, we don't know that too. And what we've seen in some states that have already reopened, we've seen spikes in the cases. Like, so for Georgia, for example, we saw a spike as some of the restrictions loosened, and the same went for Florida. So again, I just want to underscore that it's not just the New York problem, and I'll repeat that line I like, an outbreak anywhere is an outbreak everywhere. We have people moving between the states even now during lockdown measures. I know when Alabama opened, they said about 25,000 people came into the state from surrounding borders of states that were closed. So we really need to take this seriously. And trust me, I want things to go back to normal as much as everybody else does.
Yeah. Thank you, Dr. Parikh. So our next question goes to Dr. Tejwani. Dr. Tejwani, share with us what you think about the long-term COVID lung impact. You spoke about this before, but this specific question comes in regard to, will these patients be labeled as asthma patients, COPD patients, ARDS patients? How do you think they'll be diagnosed and develop long-term lung progression after post-COVID?
I think that's a great question. So we'll have to extrapolate a little bit from what we see from other viral induced lung injuries, and we have dating back to the Spanish flu and well before that, a kind of long history and data with that. There really is no diagnostic label per se. So most patients that survive won't have any asthma, COPD, or persistent lung damage. I think the risk is going to be, are their muscles weak and are they just generally deconditioned? Is there psychological and cognitive impact, which we do see, including up to 12 months after the hospitalization? And then a small percentage of them could have permanent lung scarring, and this would be less than 10% from the initial lung injury. So most people that recover will have kind of a 12 months of a slow return to normalcy. A smaller percentage will either have persistent lung scarring or new onset asthma from a virus.
Thank you for that clarification. That is so incredibly helpful and a common question that we have fielded at the network. The next question actually goes to Dr. Parikh and is from a school nurse who shares her concern over children that are coming potentially back to school with cystic fibrosis or severe asthma. Perhaps they have trachs, vents, or nebs, maybe cognitive impairment and the inability to socially distance. What would be your advice for a school nurse dealing with that situation?
Right. So, if you are a school nurse in a situation where you're taking care of a high risk population, especially those who are immunocompromised or may have lung disease or are trached or vented, then I think it will be up to the school to put in measures. I mean, all schools anyway are going to have to put in measures before they reopen. And the CDC actually has outlined them. But I think these type of schools will have, where there is cognitive delay, they're going to have to put in different measures. So will that be limiting how many children are in a classroom at once? That's a possibility. Will that be those schools may need to reopen later? I don't know for sure, but yes, I think then it will be on the school kind of to make sure it's a safe learning environment.
Great, thank you, Dr. Parikh. I'm sorry, I had a moment of technical difficulty. So the next question does come for Dr. Tejwani, and is in regard to antibody testing. This is someone who had symptoms, and they had the antibody test done, but nothing showed up, meaning that they didn't have the virus. Is that possible, and are all tests reliable?
Yeah, that's I think a great question, and honestly, it's a critical question as we start to look to open up more broadly. So I think the antibody testing, I think the most recent validated one is from Abbott Lab. There was some report, but I think generally has been well accepted that it's reliable for exposure or not. So I think to that individual with some degree of certainty, it's likely that the symptoms that they had were not COVID related. I would caution that it's not 100%, but is somewhat reliable for exposure. I think a secondary question, which I just want to point out, even though it wasn't directly asked, is if that antibody equates to protection. And I think as we transition to a opening back up, particularly in some type of staggered fashion, that question is going to be critical. The closest evidence we have for that right now is in actually monkey studies or macaques, where they did not reinfect after exposure 4 weeks later. And that seemed to be the case for SARS-CoV-1 as well. So those are both encouraging. To that particular individual, I would say it's likely that those symptoms therefore represented something else, but cannot say that with 100% certainty based on the antibody test.
Thank you for that clarification. And many of the questions that are coming in actually are regarding school nurse guidance and school reopening guidance. I do want to reassure you all, Allergy and Asthma Network is working alongside experts in this area specifically to develop an algorithm and a position statement for school nurses and also for school personnel on reopening to support specifically patients that are living with chronic respiratory conditions. So that will be forthcoming and will be on our website within the next 10 days. Our next question goes to Dr. Parikh and is in regard to, should people be going to restaurants and participating in air travel yet?
Right. So I would caution against restaurants and air travel, because we know most of this outbreak and pandemic occurred from, air travel between countries. So absolutely would not travel on airplanes unless it's absolutely necessary. And then the same also goes for restaurants. I would do it with extreme caution. Again, it's hard to know who's exposed, who's been exposed, where people have been. The most control you have is around your immediate environment. And of course, we always say this to our food allergic patients as well. So again, you know, I know that the urge is there, but right now, until we have more information, until we have more reliable testing, as Dr. Tejwani had mentioned, I think it's too risky.
Okay. So our final question here that we have time for is from Linda, and she asked Dr. Tejwani, is there any evidence that nebulizer treatments may actually create a pathway for SARS to enter deep in COVID-2 to enter deep into the lung pathways? Will it be important to give nebulizer treatments in an environment with increased protections?
I think that's a really important question. And the other kind of related question is for people with sleep apnea and other types of conditions that need CPAP or those face masks that people use at night. As far as I know, there's no evidence that the nebulizer or mask itself can introduce the virus. I think the bigger concern with those, and actually a reason we are not currently using nebulizer therapies in our COVID intensive care units, is that they can aerosolize the virus. This is a theoretical risk. It's been studied in labs, so we don't know if that aerosolization actually leads to increased transmission, but irrespective, it shouldn't actually deliver the virus deeper, but I think if that person is carrying the virus, there is a risk that it aerosolizes it to people around that individual.
And just one final question, Dr. Parikh, several questions around camps this summer. And what would be your advice on the opening of camps or closure of camps, specifically even for high-risk communities like asthma camps?
Right. So I think as of now, camps probably should be closed, given that most schools have been closed for the rest of the school year, and usually camps follow shortly thereafter. Again, because we have camps in all different regions with all different communities, we need more time to see that deceleration, not just in New York, but all over the country before we can even consider that. And as I mentioned earlier, other parts of the country we're seeing actually still in the acceleration phase. So the curve is going up. So right now, I think camps should stay closed.
Thank you, Dr. Parikh, and thank you, Dr. Tejwani. Both of you have been such a wealth of knowledge and information this afternoon, and we greatly appreciate your expertise and participation. I'd like to take a moment just to thank you all for listening today. The COVID-19 situation is certainly rapidly evolving, and we here at the network are going to continue to keep you informed and prepared for what lies ahead. Our next COVID webinar will actually be on June 4th at 4 p.m. Eastern time, and we'll talk about the new normal, even as Dr. Tejwani used that terminology. The new normal, what will that look like for all of us? We'll discuss the current state of COVID-19, as well as health and economic impact issues. So thank you again for joining us. This is Tonya Winders on behalf of the staff at Allergy and Asthma Network. We hope you stay healthy and safe each and every day. Thank you and have a good afternoon.